our next talk is from Dr. Sarah Sanghavi.
Okay, I'm starting early, but I promise I won't fill all the time. Let me get this up. All right, Kate, do you see what you're supposed to see?
I do.
Okay, great. Okay, good morning, everyone. And yeah, Anna, thank you for that excellent talk. So my name is Sarah Sanghavi, for those of you who don't know me. I'm a clinical associate professor in the Division of Nephrology and a critical care physician. I have no financial disclosures. And we're going to start off with, I should probably tell you, my talk is MAP targets and AKI. And we're going to jump right to it with a case. So this is a thin 60-year-old woman who I saw recently. She comes in with septic shock due to strep bacteremia from a lower extremity wound. She does require some low-dose norepinephrine for blood pressure support. And on admission, she has acute tubular injury. Her creatinine is 4 milligrams per deciliter. Urine output has been averaging about 10 to 15 milliliters per hour. Her lactate and mental status are normal when we target a MAP of 65. And generally, she's been achieving a MAP between 65 and 70. We've been using cuff pressure. She doesn't have an arterial line. Now, on day 5 of admission, after she's received days of antibiotics, she's cleared her blood cultures. Her norepinephrine requirement has improved, but she still needs about 0.1 mics per kilogram per minute. That works out for her to about 5 micrograms per minute, which is what I call like a whiff of norepinephrine. And unfortunately, her creatinine and urine output have not improved over this time. So this led us to a few questions. The first one was, should we target a higher MAP to improve her renal recovery? Could we target a lower MAP to liberate her from vasopressor infusion? And that's knowing that in keeping someone on vasopressors, we're keeping them committed to a central line, and that increases their risk for a catheter-related bloodstream infection. We also generally have to keep them in the ICU for that reason, and increases their ICU length of stay. One of the concerns with this approach is that because she has ATN, we won't be able to use urine output as a measure of renal perfusion. We also wondered, is norepinephrine helping her or hurting her at this point? Now that we're at day 5, we know norepinephrine is both an alpha and beta agonist. Is that alpha agonism actually causing vasoconstriction that's harmful to her kidney recovery? And lastly, should a nephrologist be worrying about this? So we'll answer the first 3 questions in the next 25 minutes or so, but I can answer this last one now, and that is yes. So yes, a nephrologist should be worried about this. Okay, so in order to address these questions, we need to start with the phenomenon of renal autoregulation. Oops, sorry, did I move you guys? Does my screen still look normal to you, Kate?
Yes, looks
okay,
normal.
Great.
The auto-regulation side. Yep.
Okay, wonderful. So autoregulation is this phenomenon by which changes in systemic blood pressure do not affect renal blood flow. So renal blood flow remains constant. And you can see that over here on the flat portion of the line. An optimal autoregulation generally occurs between a systolic blood pressure of 90 to 150. Now, the lower limit over here of autoregulation in the kidney is actually a lot higher than it is for the heart or brain. And that's great because in states of shock, blood is preferentially shunted to the heart and brain and away from the kidney, but also means the kidney is more prone to injury at lower blood pressures. Now, at the higher inflection point here of autoregulation, it does prevent excessively high systolic blood pressures from damaging the glomerulus. And you can see that in people who have chronic hypertension, this entire curve is shifted to the right to offer further protection for people who have hypertension. And renal autoregulation occurs by 2 mechanisms. There is the fast myogenic mechanism, which works with between 3 to 10 seconds, and then a somewhat slower tubular glomerular feedback, which takes about 20 seconds. And so this is what it looks like in an animal model. And you note the difference in scale over here on the y-axis. So this is renal blood flow in milliliters per minute. This is blood pressure. And you'll see that for significant changes in blood pressure, the renal blood flow remains just remarkably stable. It's essentially a straight line. And to put this in Seattle terms, let's say you are on a particularly strenuous bike ride, lots of hills, maybe even rain, your blood pressure is rising. Now, if this caused a similar rise in renal blood flow and GFR, that could potentially exceed the resorptive capacity of the tubules and result in salt wasting. So just, imagine the amount of Gatorade Dr. Dwolski would have to keep on hand just to prevent volume depletion in this scenario. Okay, so we're going to break down the components of renal autoregulation, and we'll start with this myogenic response. So the myogenic response involves stretch activation of mechanosensitive ion channels, and it responds to transmural pressure and can actually be demonstrated in the absence of flow. So it's really a pressure phenomenon, not a flow phenomenon. And you'll see here that both vasoconstriction and vasodilation occur really fast. In this animal model here, you'll see that when we keep the map around 140, the afferent arterial diameter vasoconstricts. And then when we drop the map to renal arterial pressure to about 80, you get this vasodilatory effect. Now, over here on the right, you'll see that instead of using a constant arterial pressure, they used very high frequency pulses. And this resulted in a mean pressure that was about 30 millimeters of mercury lower, but the same peak pressure. And you'll see that they had a similar vasoconstrictive effect. And what this means is that your myogenic response is actually responding to peak pressure, not MAP, which is interesting because when we take care of patients, we often think in terms of MAP, not in terms of peak pressure or systolic pressure. All right, the second part of the autoregulation is tubular glomerular feedback. And the goal of tubular glomerular feedback is to really maintain renal blood flow and increase GFR in states of volume depletion. And so you'll see that sodium chloride concentration is sensed by the macula densa cells, and they activate adenosine to vasoconstrict in settings of high concentration, or prostaglandin E2 to vasodilate in settings of low sodium chloride concentration. And then the sodium chloride concentration can also, in states where it's low, can also activate renin secretion from granular cells here because they're very close in approximation. And that will activate the renin-angiotensin system. Angiotensin 2 will vasoconstrict that efferent greater than afferent arteriole and lead to an increase in GFR. That occurs in over 5 to 15 minutes. Okay, so do disease states modify autoregulation? This is all well and good under normal healthy conditions, but what happens when people are sick? And so this is a study of 10 liver transplant patients who had vasodilatory shock. And what's cool about this is that they also had renal vein catheters in place. And the authors infused norepinephrine to achieve different MAP values. And they measured urine blood flow, renal blood flow, GFR, and found that all of these parameters improved when MAP was increased from 60 to 75. But there wasn't a major difference when MAP then increased from 75 to 90. And that suggests that 60 is probably below that, that straight line of autoregulation, whereas between 75 to 90, you're in that autoregulation area. And you can see here on this graph, GFR is on the y-axis, MAP here, considerable increase in GFR with increasing MAP to 75, and pretty stable from 75 to 90. Okay, so what about septic shock? This is a little harder to measure in terms of having renal vein catheters placed. So this is an ovine model of hyperdynamic sepsis. And these authors found that renal autoregulation was actually not impaired. And then when they administered pressors, they found that when they administered vasopressin, that lower limit of renal autoregulation actually decreased, meaning that renal blood flow was preserved at lower renal pressures. And with norepinephrine, they found that renal blood flow overall was increased. And it's important to point out here that when we think about sepsis and vasodilatory shock, that's the kidney injury in these states is largely due to the inflammatory response resulting in endothelial cell activation, alterations in the microcirculation, and not necessarily an ischemic reperfusion injury. Now, these here are all animal studies of true ischemic reperfusion injuries because the renal artery was clamped. And all of these studies show that ischemia reperfusion injury results in impaired renal autoregulation. So whereas we may not see that in vasodilatory states, we do see it when people have true ischemia reperfusion injury. Okay, so that's it for renal autoregulation. And now we're going to move on to clinical studies of MAP targets. Now, the first one, many of you may remember, it was called Sepsis-PAM. It was a large study performed in 29 centers in France, including 776 patients. It was an open label RCT, and the high target MAP group targeted a MAP between 80 to 85 millimeters of mercury, and the low target was 65 to 70. Their primary outcome was 28-day mortality. Patients were mean age of 65, and 45% of them had AKI at enrollment. And you'll see here on this graph, they actually achieved a MAP that was even higher than what they set out to do. So in the low target group, the MAP was actually 70 to 75 on average. And in the high target group, it was 85 to 90. I'll mention that fluid balance was similar in both groups at about 2.5 liters. As expected, more vasopressors were used in the high MAP group, and overall, there was widespread corticosteroid use at this time in 2014. And so the authors found no difference in survival between the high target or the low target group. They did note that the main adverse event was atrial fibrillation, which was more prevalent in patients who are in the high target group. And that was about 6.7% versus 2.8% in the lower MAP group. And when they looked specifically at renal outcomes, they found that overall there's no difference in the low MAP or the high MAP group. But when they specifically looked at people who had a history of hypertension, so chronic hypertension, they found that there was a difference in doubling of the creatinine, where the low MAP group had a much higher incidence than the higher MAP group. And that's same for looking at the outcome of renal replacement therapy. Notably, only 340 patients had chronic hypertension in the study, and this was a subgroup analysis. We don't have a subgroup analysis of patients who had AKI at enrollment, so we don't know if those patients fared better with one strategy over another, looking at prevention of AKI versus recovery of AKI. But after the study was published back in 2014, there was a lot of people coming out promoting individualizing MAP targets in people with sepsis and septic shock. And then the 65 trial came along, and this is 6 years later. And in this study, 65 doesn't just refer to a MAP greater than 65, but it specifically looked at people who were 65 years and older. And this was based on a pilot study by the same group, where patients who were over 75 actually had benefit with lower MAPs and decreased pressor usage. And so the title of this study is The Effect of Reduced Exposure to Vasopressors on 90-Day Mortality in Older Critically Ill Patients Who Have Vasodilatory Hypotension. It was a pragmatic trial that occurred at 65 ICUs in the United Kingdom. The average age here was much older, or at least 10 years older at age 75 compared to Sepsis-PAM, which was 65. It was a larger trial, had 2,600 patients, and in this trial, 1,200 of them had chronic hypertension. Notably, 540 did not have sepsis, so they had other forms of vasodilatory shock, and the second most common type of vasodilatory shock besides sepsis were post-operative vasodilatory shock in surgical patients. They were randomized to a MAP target of 60 to 65, what the authors characterized as permissive hypotension. And the other arm was usual care. And there was no information, unfortunately, on AKI at enrollment in this trial, but we do know that only 1.5% required renal replacement therapy on enrollment. And so these are the MAPs achieved in this study. Permissive hypotension MAP group was 66.7 millimeters of mercury. In usual care, it was 72.6. So overall, it was about a 6 millimeter mercury difference. Steroid use and fluid balance were similar between both the intervention and control arm, and average fluid balance was positive 1.5 liters, really, through the first 7 days. And this is important because we know that if someone has a very high CVP, that can definitely affect renal perfusion pressure. So again, the 65 trial showed no difference in survival. I will mention that interestingly, there was an unexpected signal toward lower mortality in the permissive hypotension group among those who had chronic hypertension, which is the exact opposite of what you would expect and what that was seen in the sepsis PAM trial. Can't really explain those findings based on what we know about autoregulation in the brain, the heart, and the kidney. Notably, there was no difference in arrhythmias when these lower MAP targets were used compared to sepsis PAM, which had much higher targets. And when they looked at renal support, they found that maybe slightly less people in the permissive hypotension group had or required renal support if they did not have chronic hypertension, whereas slightly more required renal support in people who did have chronic hypertension. So similar to what we had seen previously. And it's very possible that this small difference in achieved MAP in this study just wasn't large enough to show outcome differences. But overall, I would say this trial doesn't support a MAP target of 60. Okay, so we're going to switch gears completely to cardiac arrest patients, because cardiac arrest really is a situation where ischemia reperfusion injury is more likely to occur than in septic shock. And so this was a post hoc analysis of 851 patients who sustained an out-of-hospital cardiac arrest and survived more than 48 hours, who are part of the targeted temperature management trial, which was a big study looking at 33 to 36 degrees post cardiac arrest. And I know that these slides look somewhat doctored, but it's just because I don't see well, so I had to add color. And so you'll see that the low MAP group is over here in light gray, and that was less than 70 millimeters per mercury. The intermediate group was 70 to 80, and that's noted in blue. And then the high MAP group is a MAP greater than 80, and that's noted in green. And you'll see that among all patients, GFR was higher at higher MAPs. And they specifically looked at people who required high doses of vasopressors, so people who didn't achieve these MAPs naturally, but due to medications. And they defined high vasopressors as greater than 0.1 micrograms per kilogram per minute of norepinephrine. There were equal percentages of high dose pressor use in all MAP tertiles. And again, they found the same results, that GFR was increased at higher MAPs. When they looked specifically at the incidence of acute kidney injury, they found that low MAP group, it was about 54%, whereas in the higher MAP group, it was 42%. When they looked at renal replacement therapy, it was 13% in the low MAP group compared with 4% in the high MAP group. So definitely looked like there was a difference between lower MAPs, less than 70, and higher MAPs. Now, that trial only measured MAP at admission, 4 hours, 12 hours, and 20 hours. So it may have missed some significant hemodynamic changes. So this study is a post hoc analysis of a prospective observational study that actually had continuous MAP measurements. Again, this is after out-of-hospital cardiac arrest. And they looked specifically at percentage of time under a MAP threshold. And you can see the different colors and the MAP thresholds they used. And they found that for every decrement in MAP threshold, there was an increased risk of it was associated with an increased risk of severe AKI. And the adjusted odds ratio was about 1.5 for people who had a MAP less than 65 for developing severe acute kidney injury. So there may be certain situations, such as pure ischemic injury, where a higher MAP is actually helpful. But these are all post hoc analyses, and more data is probably needed here. And so lastly, I just want to touch on other methods of augmenting MAP, because many of us have seen midodrine used for intradialytic hypotension. So the question becomes, should it be used in the ICU to liberate people from this vasopressors, from their need for a central line, from extra days in the ICU? And in this study, which was very small, it was an RCT of 66 surgical patients who were on rather low dose norepinephrine. They added midodrine at a dose of 20 milligrams Q8 hours, which I would say was a robust dose of midodrine, and found that they didn't have any difference in vasopressor discontinuation rate or the length of ICU stay. They did have an increased risk of bradycardia, which is a side effect of midodrine. This was confirmed in another pilot study called the Maverick trial, but enrollment in that study was stopped early because of COVID-19. So it's still an active question, and there's a trial that's called the Liberate trial that's currently enrolling with a goal enrollment of 350 patients in Canada. Okay, so now let's go back to our cases for the remaining questions. Should we target a higher MAP to improve renal recovery? And again, this is our patient with vasodilatory shock, who's 60 years old. So it seems like a MAP of 65 is sufficient for most. Chronic blood pressure may help inform blood pressure targets, however, and it doesn't seem like there's any harm in targeting a MAP of 70 to 75. Could we target a lower MAP to liberate her from vasopressor infusion? It seems like a MAP less than 65 really hasn't been adequately studied. So I would say that that's probably not a safe thing to do at this time. Is norepinephrine helping or hurting this patient? Well, we know that norepinephrine seems to improve renal blood flow. If we're on high doses of norepinephrine and concerned about developing arrhythmias, it may be useful to add vasopressin in that situation to lower the norepinephrine dose. And midodrine for vasopressin liberation really requires further study. We don't have any positive outcomes as of yet. This is a question that's still being debated. There are more trials coming out. There's another one called OPTRESS, looking specifically at elderly patients with septic shock that will be occurring in Japan and is currently enrolling. So what about post-cardiac arrest? So should we target a higher MAP to improve renal recovery in these patients? And at least from the data we have so far, a MAP goal of 70 may be helpful. We don't know for sure, but it's unlikely to be harmful. Could we target a lower MAP? I would say no at this point. And part of the reason is I don't think we gain anything from targeting a lower MAP in this population. Many of these patients are still going to require sedatives and need their central line for access. They're going to be on mechanical ventilation, so it's not like we'll be able to decrease their ICU length of stay. And it seems like there might be potential for an increased risk of AKI in these patients who do have ischemic reperfusion injury. So I'd say we don't know the optimal MAP target here, but overall I would probably err on the side of higher rather than lower. So that's all I've got. I'm happy to take questions. I will note that I've adopted, I should say, the Huskies as my new football team. So I will be watching them on New Year's Day from my parents' home in Texas. That's all I got.
Thank you, Sarah. Really nice. Questions for Sarah? From Nisha.
Sarah, great talk. Really interesting. Thank you. I'm curious about, I know you mentioned midodrine at the end. We see that a lot. A lot of people transitioning off of continuous pressor support onto midodrine. What is your practice as an intensivist in that regard?
Yeah, well, this happens a lot just because of the ICU bed shortage. And so if we get people onto midodrine off of pressors, not only are we decreasing their potential risk of a catheter-related bloodstream infection, but we also free up a bed for someone who may need it. And with resource limitations, I think that's something that people often want to do. But I would say that I don't, based on what I've looked at so far, we've now had 3 small studies that don't show any benefit. And, potentially the beta agonism that you get from norepinephrine that you don't get from midodrine is helpful in people who have septic shock, who may still have some myocardial stunning, even subclinical myocardial stunning. So I, would, unless there's a lot of concern over, hygiene or, something with the central line, I would probably still keep those people on that low dose norepinephrine. As much as it bugs me, as it bugs everyone else to just be like, oh, just turn it off. I think it is probably appropriate to keep them on norepinephrine until we have better data to support midodrine.
Thank you.
Leah?
Thanks so much, Sarah. That was fantastic. I guess I'm still struggling as someone who grew up with only systolic blood pressures and no maps that we ever looked at. Your early slide showed quite clearly that the kidney responds to systolic hypertension in terms of its autoregulation phenomenon. So why are we spending all this time looking at maps and not just looking at the systolic blood pressure like we used to? So
yeah, very good question. And I think it's probably more related to brain and heart that we do map, because we're worried about diastolic pressures filling the coronaries. And I think that's the main reason. I do agree that if we're at this higher blood pressure level, really, we don't have to worry so much about cerebral perfusion or cardiac perfusion when we're talking about MAPS in the 60 to 65 range, because the autoregulation of those organs is lower, that we probably could look at systolic. And that's another kind of cheat measure we use in the ICU a lot too. A lot of our patients with septic shock have these wide pulse pressures because they have hyperdynamic circulation. And often we will say, well, let's just use a systolic goal of 90 instead of a MAP goal of 60 because their diastolics continuously run very low. So I think that is something you can do if you're, if you're sure that your cerebral perfusion pressure is fine, or if this is a patient who's awake and talking to you. And so you would know if you were dropping down below that level of autoregulation. So I think, yeah, that's definitely something that can be done. I looked as hard as I could to find any data on systolic blood pressure used in people with shock in the ICU and titrating pressors to that, and I couldn't find anything.
But for our patients with isolated AKI on the floors who are running lower blood pressures without cardiac or cerebral problems, it's acceptable to focus on their systolic blood pressure rather than their MAP when. So,
I mean, physiologically, it would be acceptable, but I can't prove that with any data beyond physiologic data.
Okay.
Excellent question.
Sorry. Question from Karen.
Thanks for the talks, Dr. Sanghavi. That was really great. Just curious if in the data that you looked at, whether you saw if there was any difference between MAP targets and different types of shock, or if that was differentiated at all.
Yeah, so I think it's hard because a lot of the data came from people with vasodilatory shock and post-cardiac arrest. The cardiac surgery patients who likely have cardiogenic shock, there's too many confounders in those patients because they were getting blood transfusions and significant amounts of fluid in surgery. So that was going to change some of the parameters we were looking at, change the CVP, which will affect mean perfusion pressure. So at least looking at people who had out of hospital cardiac arrest, that there's still an inflammatory response there. So there's probably still some vasodilatory shock. In the study I showed you, most people actually had a preserved EF or just a moderately reduced EF, so between 35 to 40. There were actually very few who had a very low EF. So I would say that I wasn't able to really parse out cardiogenic versus vasodilatory shock in these instances. All the hemorrhagic shock models we have are animal studies, and that does show impairment in renal autoregulation, but we don't have human studies for that. So I would say to sum up, I don't think we have that level of granular detail to really say at this time whether different states of shock require different MAP targets, but at least we can say that different types of kidney injury potentially require different MAP targets.
Thank you.
Last question from Ian.
Great talk, Sarah. Any explanation for those apparently contradictory subgroup analyses by hypertension status in the 65 trial and the prior trial?
Yeah, no, it's so weird. I will say that the 65 trial, their confidence interval went to 0.99. And that data hasn't been replicated at all. So I don't know. There's no biological plausibility that works for me there. Just knowing that hypertension in general is going to shift that regulation curve to the right. So I'm just going with the sepsis PAM data and saying I don't necessarily believe the 65 trial data, only when it comes to those patients with chronic hypertension having lower rates of mortality. I don't have a good way of explaining that. I don't know if do you have ideas?
No, I mean, it's not really. I think we have to have some humility in these subgroup analyses that are exploratory, and it's hard to know how to interpret. The sepsis PAM trial did look like there was a qualitative interaction where the intervention was harmful in one group and beneficial in the other group, or the estimates were that way, which is a little hard to believe. And I think that those qualitative interactions are rare. And so I think it's uncertain. I don't know. It's really hard to know what to make of those data. I don't have a better answer.
Yeah.
Really nice talk. Thank you so much, Sarah. Great discussion.